Okay, thank you very much and good afternoon. Thank you to the organizers for inviting me to give a quick presentation. I'm bringing you the future. You'll come back to the past after I'm done. Hope you'll find it exciting and you see what I'm going to present to you and see what I'm going to say reflects and builds on what you would have heard. There's something with you called TCCD, transcranial color-coded duplex ultrasound. I must stress that this is based on the principles by the other speakers, and Dr. Pham gave a very nice lecture. Please remember her talk when you go through mine. I'll cover the following areas in the course of today: some brief introduction remarks, how to perform transcranial color-coded Doppler ultrasound, the indices and criteria as already explained by Dr. Pham very nicely, the where you must be careful, what mistakes you should not make, how to compare TCD, which is a blind technique, with what I'm going to show you today called TCCD. Then this will guide you for treatment of your patients before making some concluding remarks. So here's a patient you may have seen just yesterday. A gentleman, 67 years old, who's right-handed, who has hypertension, hyperlipidemia, smoking, noted when he woke up to have left-sided weakness and unclear speech. He was rushed to hospital, and when you examine him, there were no cortical signs, no aphasia, no drowsiness, no gaze deviation, had a mild left facial droop, tongue deviation, and left-sided severe weakness. So in your mind was a small right subcortical infarction, and your scan does show, in your CT scan, it shows a striatocapsular infarct. Now, as you know, this can reflect occlusion of multiple lenticular striates in the MCA. So it may not be small artery disease, maybe large artery disease, maybe stenosis of the middle cerebral artery, or cardioembolic, or even artery embolism. So the question you have is, so what caused this patient's stroke? The ECG has been done, it's normal. The echo and the Holter are pending. The cardiologists are having lunch. They have no time to do the study for you straight away. And you had the speakers here do the ultrasound for you. It shows some plaques, but it's non-stenosing. The question is there stenosis in the right intracardiac artery, intracranially, right MC or ACA? That's the question you ask. You want to do TCD, but the machine is gone for repair, so you can't use it. What else can you do? There are a few ways of looking at the brain. One is CT angiogram, MR angiogram, full angiogram. Why bother when you have the answer TCCD? So traditionally, TCD has been used for many, many years to study the brain arteries. You'll have a lecture on this a little later. The new technique I'm going to tell you about is called TCCD, with many other names to describe the same technique. What it does is it combines what you will learn about ultrasound, which is a B-mode imaging of vessel as well as blood flow, together with only blood flow, and together come with a technique that puts it all together under one heading. When do we do TCCD? For the same reasons as TCD, looking for stenosis, as you've heard already, vasospasm, what happens in the brain when there's trouble over here. And you can even use it for ultrasound sonothrombolysis in some centers. But more than TCD, it can do some other things. You can sometimes, with good machines, actually see abnormal structures in the brain. And if you're doing movement disorders, you can see the substantial Niagara in very high-end machines, which we don't usually do. So when there's no TCD, what you can do? TCCD, which is the talk for today. The technique, the summary is in this slide. If you hear this slide, my talk is done. Firstly, you need a very, very good machine. High-end ultrasound machines as you'll work with today, with the appropriate software to process imaging of the brain blood vessels. The probe is a low-frequency probe. Low frequency, as you've heard, to allow deep penetration into the skull tissue. The windows you'll use are the same as TCD in the temporal window, the middle cerebral artery, anterior posterior artery, and the terminal intracardiac artery. To the foramen magnum, you can study the intracranial vertebral artery and the basilar artery. To the orbital window, the siphon and ophthalmics. You'll hear this over and over again by the other speakers too. The windows you use are the same. But what's different is, by using this technique, you must first find the landmarks, find out where you are, because it's not blind. You can see everything that's going on. And then, after you found the landmarks, you then put the color to see where the flow is, and then you get the flow. So here's what I'm going to show you how it's done. So first, transtemporal window for the MCA, ACA, PCA, and terminal ICA. How do you do this? The probe is put here. in the patient's skull. When you put it here, the patient is lying flat in bed very comfortably with a pillow if you like. You're standing behind the patient. Patient is there, you're standing behind. Take the gel, first turn on the machine, good. Collect the probe, put the gel, and put it over the temporal window. Not too far front, not too far behind, because only a few areas here you can access the bone allows you to get through into the internal structures. Once you're there, you use the B mode, increase the depth until you can see the skull on the other side. The first landmark is find the skull on the other side. The second thing you do is then find the midbrain, which is a small like a butterfly in the middle. The skull is usually 15 centimeters across. The middle brain is about 7 to 8 centimeters in the middle. Once you've found this butterfly of the midbrain, you then put the color. Beautiful flow can be seen. What vessel goes around the midbrain? What big artery goes around midbrain? You heard just now? The posterior cerebral artery. And just in front is the middle cerebral. So by knowing this location, how it looks, and how the blood flows, you will know which artery you're in. I'll show you a picture in a minute. Having found the arteries, you know where you are, you then put the sample volume and look at the velocities. As you heard earlier, the systolic, diastolic, all be revealed to you. By using Doppler, you can then determine all the required parameters. So here, patient lying down, the patient is here, the probe is here, right? You're seeing all the beautiful blood vessels through this window. You're seeing, for example, here, the middle cerebral coming over here, anterior cerebral here, posterior cerebral over here, all from this window. You can see it all, and you can find the terminal ICA just a bit below. But the machine is on one side. So you must twist your mind, rotate your mind to know when you're doing here, you're seeing the same vessels. You're seeing here anterior cerebral, middle cerebral, posterior cerebral in the machine tilted onto one side. So the patient is like this, but on the screen is like this. So you must rotate your mind, the patient lying on the side. Having put the probe on, you then increase the depth, still you see the skull on the other side. You must come to this. And this is a very bright structure. It's usually 15 centimeters in adults. And between this beautiful butterfly is the midbrain, the peduncle itself, cerebral peduncle, and then the midbrain, usually at 7 to 8 centimeters from the probe. The probe is here, the other side of the skull is here. You're then seeing the beautiful midbrain just about there. And this is the MRI equivalent. What you see here is what you see here. The next thing, the next is find the midbrain very clearly again. You see beautiful peduncles here and the midbrain here. And what vessel goes around the peduncle? The posterior cerebral artery. So put the color on and everything is revealed. You see on the probe is here, skull is here, midbrain here, and this is the PCA coming towards you. It's coded red because it's coming towards you. This is the contralateral PCA. In some people, you can see both ipsilateral and contralateral. What's in front is the MCA, beautifully coming towards you again. What's flowing away is the anterior cerebral artery. So you see in this single window, you can see usually everything if you put it right. PCA, MCA, ACA of that side, and the opposite side PCA, opposite side ACA, and maybe some opposite side MCA as well. All can be beautifully seen. So having first found these structures, you can now label them. You put a picture on the screen and label all the arteries for you to keep for future reference. The PCA on this side, MCA, ACA, and opposite side PCA, opposite side MCA. So do this first. Landmark, midbrain, color flow, find the vessel, freeze, label them. Having done that, it's easy after that. You put the Doppler sample in each of these vessels and find out what the velocity is. You can increase by say 2 to 3 millimeter depths to find the part of most severe stenosis. Because you have color-coded Doppler, it can tell you where the turbulence is. Where there's turbulence, that's where the most stenosis is located. So you quickly find the MCA, PCA, MCA, ACA, PCA, and the siphon. So, and the terminal ICA, right? Here you see beautifully in this patient on the MRI, MCA coming here, you see that? ACA here, terminal ICA here, and this is the opposite side. exactly here you see on your TCCD. You see the MCA, so you see the PCA here, MCA, ACA, and the opposite side vessels too. All very beautifully seen. Then you put the Doppler mode, you know in the right location. So this is how we do the transtemporal TCCD to detect MCA, ACA, PCA, and terminal ICA. Having done these vessels, the next thing is to look at the posterior circulation at the intracranial vertebral and the basilar artery. And the window is here. So the patient's lying on one side, you bend the head much as you can, so you have a good window and try to open up the foramen magnum. So in this patient, usually lateral or lying flat, you must turn the head a lot, which is not very comfortable for the patient. Actually, I prefer lying on the side, to be honest. Turn on the machine, of course, gel on the probe. Use the probe back here and try to find the foramen magnum. It's a big black hole. Once you found this black hole, you then put on the color-coded Doppler. You should see the two vertebral arteries flowing in and going into the brain. That's the basilar artery. Having found it, the same thing, put the Doppler volume, a Doppling sapler volume onto place, find the direction and the velocity as you heard from Dr. Pham earlier today. So here's an example. The probe is here, the patient is lying on the side, and here you see the vertebral artery, 1 and 2, and then you find the basilar artery coming through. Sometimes you can even see the pica appearing off the vertebral artery coming towards you. So generally this blood flows away from you into the brain. So it's a very quick technique to pick up the pulse circulation. Having found this, you can then put in the sampling volume and find the velocities at various depths on the vertebral and the basilar artery. Next is the transorbital window. You must remember, you must lower the power, because the power, it can damage the eye, can damage the lens. So please lower the power to 10% of the power you normally use. But you can very nicely see the ophthalmic and usually the siphon as well. So patient lying flat like this, you lower the power, turn on the machine, put only a small amount of gel because very irritating for the eye, put it there, and first try to find the optic nerve. You'll find the eyeball first, optic nerve, put the colored Doppler, and then you can see ophthalmic artery running just on top of it. Then same thing, sampling volume, find the velocities. If you can go deeper, try to find the carotid siphon. So here are the pictures. Here you are, the probe is here, eyeball is here, ophthalmic artery underneath in gray, and here ophthalmic artery coming towards you. You go very deep and go down a bit, point downwards, you can see the carotid siphon. So all this can be seen through the orbital window. So that's how we do transtemporal, transforamen, and transorbital transcranial color-coded Doppler. It's color coding the Doppler signal. The indices you use are same as TCD. The direction flow towards you or away from you, normal or reversed. What's the peak systolic velocity? And diastolic, the machine can calculate often for you automatically the mean velocity and the various indices. We don't do angle correction. If the flow is coming, when the artery is a bit bent in its way, you just take the velocity at 0 angle. You do not correct for angulation in TCCD. This is the same as for TCD. Criteria for stenosis is the same as for TCD. This is one nice publication that lists the criteria we use for the flow velocity, that's normal, and when there is 50% stenosis or more. Why 50%? More than 50%, there's hemodynamic impact. There's reduction of flow. So we use this cutoff usually, and there are some proposals here. I advise all of you to use established criteria from the famous people, and a lot of people who have done work in this room, use their criteria and other published criteria for your lab to make a diagnosis of stenosis. So if you find it's normal, then a bit dampened, then very high velocity showing it's stenosed. Take the highest velocity, may drop after that. So take the highest velocity for that vessel, and you go searching MCA, ACA, PCA, siphon, vertebral and basilar. So you go step by step in your patient. Here are some words of warning. First, it depends on how good you are. It's not the machine, it's often us. They're very good machines nowadays. So you must spend some time, learn the technique, and make sure you know where you are. Find the landmarks, find the midbrain, find the vessel, and then do the correction. It is easier than TCD. You have experts in TCD, they'll do that in 20 minutes, you're done. I'd still take a long time to do it. They're very, very good. Sometimes you can't find a bony window. Elderly, Asian women, we know, hard to find a window. Not impossible, can be impossible. It must look very hard to find in these people. But this window, you'll always find. This window, you always find. This temporal is difficult. So don't be discouraged. Just keep searching harder. In some countries, the contrast is that you can give a special ultrasound contrast, and that can make things brighter. So your country may have it available in Vietnam, I don't know, but some countries have it. No window, you can try give some contrast to try to make the vessels brighter. So you can see TCCD is like TCD, you'll hear about it later, for the same reasons. As good, same windows. You can use echo contrast when you can't see things well because of the big window. You still need skill, but still it is safe, non-invasive. Do it as often as you like, and you always can print out the data, store it. It's very, very similar to TCD. But there are some differences. TCCD is a newer technique. Machines are bigger, a bit more expensive usually, but I think special discount in today's conference, I think. Is it correct? Special discount today, I don't know. It's a bit faster than TCD. You can be very sure where you are, but you can see the flow very nicely on the color coding of your blood vessels. You do not do angle correction, though you can do if you really, really want to, right? Unfortunately, it can't do all these exciting techniques you heard about later from Dr. Navarro, which you can't do right now. Later, maybe we can, but you can see the structure. So plus and minus. Why do we bother with TCCD? Because it makes a difference as to how you treat your patient. Here are some guidelines we're all familiar with. For example, in patients who have severe, normally we give aspirin, clopidogrel combination for those who have non-embolic stroke. If they have significant stenosis, you give combination for up to 3 months. So it changes your treatment. There are some studies showing if you see multiple emboli, some even give anticoagulants to reduce emboli detection. High dose statin, so it does change your treatment. So it's important to find the stenosis. I predict in a few years from now, we'll be stenting these arteries. Vietnam is fantastic. You do a lot of very good stenting work here, carotids, and I think intracranial too. I think it'll come in the years to come. Even here, like the cardiologist, will now be stenting the brain. And in your hands is the tool to detect the stenosis safely and non-invasively. So to end, Madam Chairperson, ladies and gentlemen, a few take-home messages. TCCD is an alternative method to TCD, which you'll hear about in a minute, to look at the intracranial vessels and the impact here from what's happening over here. The windows you use, the arteries you study, the criteria for stenosis diagnosis, how to find the artery is very similar, except for TCD is unblinded. You can be very fast to find the artery, which you'll see later when we do the hands-on. You can actually see where the stenosis is based on the turbulence, and then you can pick up the stenosis and detect it where you want. There are many pluses, maybe some minuses compared to TCD. Some are similar problems, like no window. Whether TCD both have similar problems. So don't think they're fighting. They help each other. No TCD, use TCCD. No TCD, use TCD. But TCD has very special benefits. It's very portable, the TCD machine. Go to ICU. This machine is not so easy to move. It certainly can be done. You can put a TCD machine in your backpack and rush to the emergency room. You probably can't put this into your backpack, unless a very big backpack to put it inside. But whatever it is, training is key. Come for courses, go for exams, be certified, and I'm sure you'll help your patients very, very much.